Hi, my name is Elaine Principe. I'm Chief of Interprofessional Practice and the Chair of the Restraints Best Practice Committee at Hamilton Health Sciences. I'd like to welcome you to this interactive educational video related to restraints and restraint use at Hamilton Health Sciences. Hamilton Health Sciences is committed to providing safe, therapeutic, and clinically appropriate care while ensuring a safe environment for our staff, patients, and visitors.
What do you mean I can't get out of bed?
What am I doing here? This is weird. What is this? This is bugging me. What? I need to get this out. I need to take.
Tommy, you need to wait until somebody comes and helps us.
Can't you hear me? I can do it.
No. What is this? Hey, let go of me.
You need this for medicine.
Why can't they hear me?
How can I help you?
The technical definition of restraint is placing a person under control using minimal force, as is reasonable having regard to the person's physical and mental condition. A restraint is a device, technique, or intervention used by the staff to manage or calm the behavior that can cause injury or harm to the self or others. It can be physical, chemical, or environmental. A physical restraint is a device or hands-on technique that restricts a person's ability to move freely. A chemical restraint is any medication used to decrease behaviors that put the patient or others at risk of harm. An environmental restraint is a barrier or device which restricts movement from one area to another. Our protocol at HHS has been written in compliance with the necessary legislation. First, the Ontario Patients' Restraints Minimization Act of 2001. This governs the use of patient restraints in public and private hospitals. Second, the Ontario Mental Health Act. This sets out documentation requirements with respect to the use of restraints in psychiatric facilities. Hamilton Health Sciences is a designated psychiatric facility. Third is common law. This gives the right and duty of a healthcare provider to restrain the patient when necessary, to protect that patient or others from harm and assure a safe hospital environment. Lastly is the Ontario Healthcare Consent Act of 1996. This sets out the elements of a valid consent and the test for determining capacity with respect to decisions concerning treatment. The restraint protocol we're talking about applies to all inpatient and ambulatory settings, emergent and non-emergent situations where physical, environmental, or chemical interventions or devices are utilized. The use of restraints at Hamilton Health Sciences must be respectful, thoughtful, and responsible, using the following principles. Assessment, prevention, and alternative approaches to the use of restraints are always first tried. De-escalation, intervention, and crisis management strategies are employed in a timely manner. Restraints are only used as a last resort for the shortest duration of time reasonably possible, where there is a risk of serious bodily harm to the self or others, when prevention, alternative approaches such as de-escalation and crisis management strategies have failed to keep the individual or others safe. Restraints are never used for the purposes of discipline, coercion, or staff convenience, or as a replacement for inadequate levels of staffing. In SBAR, S is for situation. Review the patient's safety and/or risk situation. What is the patient doing that may put themselves or others at risk of injury? B is for background. Review the background of the situation and the patient. Why is the situation occurring? What are the underlying causes? When or under what circumstances are we seeing these behaviors? And where is the situation or the behavior occurring? A is for assessment. Assess the alternatives and the risk for potential harm. Risks and benefits of alternatives and the risks and benefits of the use of the restraining devices or interventions must be considered. And also consider the urgency of the situation. The R stands for recommendation. A plan of care is developed and recommended by the interprofessional team. This is related to both the alternatives or the use of a restraining device and intervention. The potential for discontinuing the restraining intervention or device and the ongoing use and attempts at alternatives must be continually reviewed by an assigned healthcare practitioner throughout each shift.
You will now have an opportunity to observe an interprofessional team patient care round. Using the SBAR framework, the team will discuss a patient admitted 2 days ago with acute pneumonia.
Thank you all for coming to brainstorm with me about Mrs. Wilson. Just a reminder for you all, she's an 84-year-old patient who was admitted to our clinical unit with acute pneumonia. The reason why we're here today is we've been growing increasingly concerned about keeping Mrs. Wilson safe. She's been a little more confused as the days have gone by. She has been a bed exit seeking, has pulled out her IV line a couple times. One time it got caught around the bed rails with her trying to get out of bed. And she does have some oxygen requirements, and she's been pulling off her venti mask and desaturating. So it's just becoming a little more concerning, with trying to keep her safe and keep her, all of her medical interventions in place.
So the physiotherapy team and the occupational therapist, we have assessed Mrs. Wilson for her mobility status. She was previously independent with her mobility and ambulation. At this time, she does require a rollator walker to keep her safe, and also one-person assist for all her transfers and trips to the bathroom. We also recommended a wheelchair for her with a seat belt that she can open at times. And she does have a chair alarm as well. However, she's been successful in undoing her seat belt, and she really is at very high risk of falling. We also met with her family, her daughter, who was very concerned about her trying to get out of the bed. She was asking if we could put all 4 bed rails up or keep her somehow in the wheelchair without getting out of the wheelchair. The occupational therapist suggested maybe a tamper-proof seatbelt. We have not discussed that yet as a team. From a physiotherapy standpoint, we also try to do some just physiotherapy for her. She's not tolerating that very well because she has an old back injury and she has increased pain in her back, and also her O2 saturations are dropping when she's not using the oxygen. So yes, we are very concerned of how to keep her safe as well.
When I saw Mrs. Wilson on admission, her mental status was totally different. She was alert, oriented to name, place, time. She was engaging, interacting properly. And I talked to her daughter, and she confirmed that Mrs. Wilson is always like that. That's her usual baseline. So now hearing that she's changed like that, I'm curious whether the staff got a chance to screen her for delirium. We haven't completed the delirium screening tool yet, but we'll make sure that we do that today.
Well, she is on some new medications since she's been admitted. She's on the antibiotics, obviously for the pneumonia, but she hasn't been sleeping well, so they also started some sleeping pills on her. She's also been started on some analgesics because she was complaining of the upper back pain. I'm not sure if that might be related to her pneumonia. And she was managed on a bunch of different medications at home too, including insulin. So we might just have to look a little deeper into all her meds, see if any of them are contributing to the status and if any of them are interacting with each other.
I completely agree with you that she is presenting much differently. When we spoke with the family, they were saying that she was completely independent with her ADLs at home, her activities of daily living, and was very pleasant in personality. It's becoming concerning because she is yelling out and wanting, yelling that she wants to get out. We have tried by putting her closer to the nurse's station. We tried decreasing the stimuli in her room a little bit. We routinely toilet her to make sure that that's not a concern. And, we do frequent care rounds on her to make sure that we're constantly checking on her. So, we just want to make sure we're keeping her safe, and it's becoming a little bit more challenging, as she's getting a little bit more confused.
So last week we had another patient who presented similar to Mrs. Wilson, and the doctors recommended Haldol for her. I was wondering if she might be presenting the same, or if that medication be appropriate for her as well.
Yeah, that's a good question to ask about the Haldol. I probably wouldn't recommend starting that on Mrs. Wilson in this case. That class of medication can cause some central nervous system side effects, and she's already exhibiting some agitation, confusion, so I wouldn't want to exacerbate that at the moment.
Nancy, so just like when you get a chance to actually screen her for delirium, I would like to give you the delirium order sets document here, which is something that if you find her positive for delirium, you can share with the medical team and they can do the workup to see what's causing it.
Okay.
I was wondering if we can involve the family somehow. They did say that they wanted to be closer to mom and help the team out. So I was wondering if we can involve them as well in the care.
I think that's an excellent idea. We have, like at Hamilton Health Sciences, we have this resource. We've developed it for families, basically when a patient requires to be restrained, but staff can use this also and hand it to the family, because there are listed interventions that families can do, so as an alternative to the restraints. So I can hand that to you as well. And in addition, oftentimes when we're working with patients in the hospital, we don't know them well enough. So when you're talking to the family, if you're gonna get a chance, Carmen, to talk to the family again, we also have this tool available. It's called All About Me. And if they would like to complete some sections of it, like basic things like what makes her happy, what she dislikes, and that can be kept at the patient's bedside, so that staff who come to interact with her would know how to approach her and not to trigger any restlessness in her. So I can hand this to you as well.
It's interesting because I see on there, she actually wears hearing aids, and I'm not entirely sure that we've been the best for making sure that her hearing aids are in when we're giving her instructions, or that they're readily available or within reach for her. So yeah. Well, I really appreciate all of you coming together to help to brainstorm through some ideas to keep Mrs. Wilson safe. I think it's really great that we work together as a team like this. The next step is I will make sure that I connect with the physician group to get the appropriate orders that we need to make sure that we can keep Mrs. Wilson safe. So thank you very much.
All restraining interventions or devices require the order of a physician and consent from the patient or the substitute decision maker prior to the initiation of that intervention or device, except in an emergency situation. in an emergency situation, and we define that as when immediate action is necessary to prevent serious bodily harm to the person or to others, there is no opportunity to obtain consent prior to the restraint being used. After an emergency situation, the substitute decision maker and physician must be informed of the situation and the use of the restraining intervention or device as soon as possible. A physician's order is required to continue the use of that restraining device. To obtain informed consent, a thorough discussion, including goals of care, the care plan, interventions considered, the risks and benefits of the alternatives, and the restraint must occur with the patient or the substitute decision maker, and this consent must be documented in the patient's health record.
You will now have an opportunity to observe a vignette from a staff perspective.
Tommy.
I need to get out. What am I doing?
No, Tommy.
Where am I? What is this? I need to get out of here. I need to get out of here.
We're gonna get help.
What?
The nurse is gonna.
Nurse, I
The
need
nurse is gonna.
I need to get out. I need to get out of here.
No, that's okay.
What are we doing here? Why?
Tommy.
I heard you calling out. How can I help you?
I need
Oh, I'm glad there's somebody here to help.
I need to get this out
And
now.
you are family?
Yes, I'm his mom.
I need this out now. I need to get out of here.
Okay,
what is this?
well, we'll take care of that in just a minute.
I need to get it. I need to get it out now.
I'd like to thank you for taking the time to learn about our philosophy and our protocol around restraint use at Hamilton Health Sciences. We hope that this interactive video has given you a chance to learn about how to provide safe care to your patients while ensuring a healthy work environment for all.